My name is Kath Sackley. I'm the Chief Investigator on a trial that we conducted examining the effects of occupational therapy on a population of people with stroke living in a care home. What I'm first going to do is summarise the evidence, and this is part of our BMJ publication. So what we were looking at was, can an established programme of occupational therapy administered at participant level help maintain functional activity and reduce further health risks caused by inactivity in a care home residents living with stroke? So what we were looking at was activity and mobility, most of those activities being about self-care. The therapist was involved with each home for 3 months, and during that time delivered a targeted programme of care that was agreed with the resident and the carers and relatives where relevant. After that, we assessed whether it had any influence on measures of functional activity, mobility, mood and quality of life. We also looked at the resource use associated with this. So why did we do it? Well, we wanted to look at occupational therapy because the evidence for occupational therapy for people post-stroke living in their own homes is really good. We wanted to see if that translated to a very different environment. So it was a pragmatic parallel group cluster randomised controlled trial with economic evaluation. Random allocation of the intervention occurred at the level of the home. So it was a cluster randomised trial. Homes were randomised to either receiving therapy or to usual care, and all of the homes don't receive individualised occupational therapy. Baseline assessments were done on anybody who had a history of stroke, and we included TIA because the pattern of stroke in care homes can look slightly different to that of people living in their own home. So we included TIA. So carried out baseline assessments first, because there are problems about bias with cluster trials if baseline assessments are done after randomisation. And then randomisation was done independently by the Primary Care Clinical Trials and Research Unit from the University of Birmingham. So the therapist would use a standard goal-setting process with the resident, where areas that they were interested in addressing were the priority of therapy. And this is standard within rehabilitation practice for stroke. The homes also received mobility and activity and stroke training. And this training education session was delivered during the study for the treatment homes and afterwards for the control homes. From the assessment, the therapist would then look at constitutes routine occupational therapy, so they'd look and see whether residents would need any aids, appliances or adaptations, such as chair raisers or a grab rail, and then they'd look at whether there were task training issues, and they could also work on tasks in practice with the residents, and they could also discuss anxieties and also refer patients or residents on to other agencies if they felt that was appropriate. So for instance, people were referred for speech language therapy or for physiotherapy or dentistry or back to the general practitioner sometimes with things like suspected deep vein thrombosis. So all in all, we had 1,042 stroke survivors who were resident in 228 care homes. We chose care homes that had more than 10 beds. Some care homes are very small. And these were spread around England and Wales. And we excluded homes that were essentially dedicated to people with drug and alcohol abuse problems, or learning disability. Primary outcome was the Bartel Index of Activities of Daily Living, widely used. It's been shown to be sensitive in this population before, and it measures on a scale. We use the scale that measures 0 to 20, and lower scores indicate more disability. So all analyses were performed using an intention to treat approach. We observed no clinically important differences between treatment arms in the primary outcome measure at 3 months. The adjusted mean difference in Bartel Index score was 0.19 points higher in the intervention arm, 95% confidence interval minus 0.33 to 0.70. P-value shows that this was not significant. When the change in Bartel Index score was compared between baseline and 3 months, the odds of an improvement were similar between treatment arms. Odds ratio 0.96, 95% confidence interval 0.7 to 1.33. The economic analysis suggested that it was unlikely that the trialled intervention would be cost effective when compared with usual care. Looking at the change in Bartel Index score, again, remember this is a 0 to 20 scale with 0 being poor, at 3 months from baseline, there were very similar numbers of people who either were grouped as poor, so a decrease in score, or death, and that was about 54.3 in intervention, 52.1 in control. Moderate, 164 versus 150, so 30.4% versus 34.4% in control had moderate change, so i.e. no change or an increase of 1 point, and then good change, an increase of 2 or more points, and this is what the study was powered on. The sample size calculation was to look at that level of change, and there were 83 in the intervention versus 59 in control, so 15.4% versus 13.5%. When it came to adverse events and harms, there were none attributable to the intervention, so we didn't have any equipment failure or injurious falls during treatment. Looking at bias confoundings and other reasons for caution, the population as a whole experienced high levels of cognitive impairment. So more than 70% demonstrated high levels of cognitive impairment using MMSE, and also more than 70% were graded as severe or very severe on the Bartel Index. These issues, very severe problems, cognitive impairment that would limit communication, may put a limit on people's ability to take part in therapy. So on the one hand, this very disabled, very impaired group may have found it difficult to set goals for therapy in particular, but also it shows that we were having a typical care home population, so it's reassuring in that way. So the large geographical distribution of the different types of care home, combined with the involvement of a high number of therapists, and a population that does represent the care home population in the UK, would give us confidence to generalise our results beyond the study. I suppose it's worth summarising our conclusions here. So the neutral findings are similar to those reported in other recently reported high-quality trials conducted in the care home population. So Underwood et al. 2013, Kurz et al. 2008. These studies assess the influence of exercise on depression rating scales and the influence of functional activity on quality of life, frequency of falls. So it involves similar therapy interventions, and both of those trials reported neutral or minimal effect as well. So having chosen an intervention that has been shown to be very valuable in a population in early recovery and people living in their own home, we now need to think about tailoring interventions or developing interventions for people who have high levels of disability, low levels of function, high levels of cognitive impairment, and low levels of ability to communicate. And I think that's the challenge for the next study.